Hello everyone. Hope all of you are doing well. I am going to discuss about various abdominal wall blocks. It will be a very brief description. It is not a in-depth discussion about various blocks. I will do that later. This was actually one of my recent presentation. I presented it at Nashik, Mumbai at a CME on Regional Anesthesia by ISA Nashik branch. Thanks to the organizers and my teacher, Dr. Balavenkat sir, for giving me this opportunity. The abdominal wall is a continuous cylindrical myofascial structure between the thoracic cage and the pelvic girdle. Roughly, we can divide it into anterolateral wall and posterior wall by posterior axillary line on either side. The blocks performed through the anterolateral wall are rectus sheath block, tab block, ilioinguinal iliohypogastric nerve blocks, whereas the blocks performed through the posterior wall are transversely spatial plane block, quadratus lumborum block, and the erectospinal plane block. There is significant heterogeneity in the nomenclature and anatomical descriptions of various abdominal wall blocks. This creates confusion in education, research, and implementation into the clinical practice, which affects the teaching and training of regional anesthesia. Recently, an international consensus study led by two big bodies, American and European Society of Regional Anesthesia, they have standardized the nomenclature. I will try to follow this latest nomenclature and description throughout my lecture. Let's begin with the innervation of the abdominal wall. The anterior abdominal wall is innervated by thoracoabdominal nerves originating from the anterior rami of T6 to T11 intercostal nerves. Those are lower thoracic spinal nerves, subcostal nerves, that is T12, and the ilioinguinal iliohypogastric nerve. If you see the distribution of the spinal nerve, the dorsal rami supplies the paraspinal muscles and the skin above. The ventral rami travels in the neurovascular plane between the transversus abdominis and the internal oblique muscle. They give off the lateral cutaneous branches in the mid-axillary line, which supplies the lateral abdominal wall and ultimately terminate into the anterior cutaneous branches and supply the midline and the adjacent area. This typical distribution does not happen to the lower thoracic spinal nerves. The upper segmental nerves, that is T6 to T9, it enters the tap medial to the anterior axillary line. The other nerves enter this plane progressively more laterally. That is why the pattern of innervated nerves varies with the location of local anesthetic deposition in tap or transversus abdominis plane. So within the TA plane, the lower segmental nerves gives off multiple communicating branches to form a longitudinal tap plexus lateral to the ascending branch of the deep circumflex iliac artery. From this plexus, anterior branches arises, enters the rectus sheath from lateral side, and once again communicate to form the rectus sheath plexus behind the rectus abdominis muscle. The terminal branches ultimately pierces the muscle and supplies the skin and subcutaneous tissue above. Hence, the individual terminal nerves have multiple segmental origin. The traditional depiction of well-demarcated dermatomes is not entirely accurate. There is also a rich network of vessels within the TA plane that promotes absorption of injected local anesthetic. They are also at risk of accidental puncture, bleeding, and hematoma formation during the performance of the block and later. So, from posterior to anterior, we have erectospiny plane block, quadratus lumborum block, transversalis fascia plane block, transversus abdominis plane block, and rectus sheath block. For abdominal plane block, you can use bupivacaine, levobupivacaine, or ropivacaine, diluted concentration 0.2 to 0.25%, according to your choice and the availability of the local anesthetic. In pediatric, the dose will be 0.1 to 0.2 ml per kg, and adjuvant, I use dexamethasone. Coming to the rectus sheath block. Rectus sheath block has been used to provide somatic analgesia for midline incisions in lab as well as open surgeries. The posterior rectus sheath is unsegmented, unlike the anterior one, which has 3 to 4 tendinous insertions. Hence, the LA injected in this plane will have an uninterrupted spread. In supraumbilical region, both the internal oblique and transversus abdominis muscle aponeurosis contribute to the posterior rectus sheath formation. Whereas in infraumbilical region below the arcuate line, there is no posterior rectus sheath. The aponeurosis of all three muscles contribute to the formation of anterior rectus sheath. Rectus sheath block is performed in supine position, usually after induction of general anesthesia. The probe is placed just a few centimeters above the umbilicus and lateral to the midline. It either longitudinal or in transverse orientation, and the needle is inserted either from lateral to medial or medial to lateral direction. The tip is placed between the rectus epimysium of rectus abdominis muscle and the posterior rectus sheath. Posterior rectus sheath appears as a hyperechoic double line, or it is also known as tram track appearance. 10 to 15 cc of local anesthetic is deposited behind the rectus abdominis muscle. Tab block is used in various anterior abdominal surgeries, either alone or in combination with rectus sheath block. Unilateral or bilateral tab block have been used depending on the surgical site and the indications. According to the recent nomenclature system, now we have only two tab block. One is subcostal, another is mid-axillary. Mid-axillary one is the lateral tab block. The subcostal tab block covers the upper abdominal nerves, that is T6 to T9, lateral cutaneous nerve, and the mid-axillary tab covers T10, T11, subcostal nerve or T12, ilioinguinal, iliohypogastric, and sometimes L1. The subcostal tab block is performed along the medial costal margin in the upper quadrant of the anterior abdominal wall, and mid-axillary tab block is performed at the mid-axillary line as the name suggests. The local anesthetic is deposited in the plane between internal oblique and the transverse abdominis muscle. During performance of the tab block, we encounter two facial layers, external oblique and the internal oblique fascia. Our area of interest is the second facial plane. This landmark cadaveric study by Barrington and colleague depicted that the neurovascular structures travel below the internal oblique fascia. Hence, any injection above the internal oblique fascia or between the two layers of internal oblique fascia will be ineffective or less effective. The correct plane lies below the internal oblique fascia and above the transverse abdominis muscle. The needle is inserted from either from lateral to medial or medial to lateral direction, and the tip is placed between the internal oblique and the transversus abdominis muscle, and 15 to 20 mils of local anesthetic is injected. It is performed either unilaterally or bilaterally according to the indication and the surgery. Next, coming to the ilioinguinal iliohypogastric nerve block. This is used for analgesia for inguinal hernia surgery, cesarean section, appendicectomy, etc. Ilioinguinal and iliohypogastric nerves are the branches from the lumbar plexus with contribution from the anterior ramus of L1 spinal nerve with occasional contribution from T12. Both nerves emerges at the lateral border of the psoas major and run inferolaterally on the ventral surface of Quadratus lumborum and the transversus abdominis muscles, just superior and parallel to the iliac crest. We can block these two nerves here above the iliac crest and near the anterior superior iliac spine. The nerves lie in a fascial split between internal oblique and the transversus abdominis muscles, along with the ascending branch of deep circumflex iliac artery. Here we can deposit the drug. In the first approach, the probe is placed medial to the anterior superior iliac spine along the spino-umbilical line and or just cephalad to it. Three abdominal muscles, external oblique aponeurosis, internal oblique muscle, and the transversus of the abdominis muscle can be identified. In this, and the nerves and the vessel lie between the internal oblique in a fascial split between the internal oblique and the transversus abdominis muscle. And in the second one, it is mid-axillary. At the mid-axillary line, the probe is placed just above the iliac crest. Here, we can perform the PNS-guided ilioinguinal iliohypogastric nerve block. The point of needle insertion will be 5 centimeter above and posterior to the anterior superior iliac spine. It is performed in the tap plane. You can stimulate and see the contractions or the twitch of the lower abdominal muscles. The needle can be inserted from lateral to medial in plane or medial to lateral or in out of plane technique also. And the tip is placed in the fascial split between the internal oblique and the transversus abdominis. After negative aspiration, 10 to 15 cc of local anesthetic is injected. In pediatric patients, as I have already mentioned, 0.1 to 0.2 ml per kg of diluted local anesthetic can be used for analgesia. Here you can see the nice distribution of the local anesthetic and the separation of the facial layers. The transversalis fascia plane block was described to achieve proximal blockade of T12L1 nerves, like in case of analgesia for anterior iliac crest bone graft harvesting site. The transversalis fascia plane block is performed in supine or in lateral position. The transducer is placed in a transverse orientation just superior to the iliac crest, The internal oblique and the transversus abdominis muscles are traced posteriorly. This is the external oblique, internal oblique, and the transversus abdominis. These are traced posteriorly until they are observed to taper off into a common aponeurosis, that is the transversalis fascia. Local anesthetic is injected in the plane between the transverse abdominis muscle and the transversalis fascia. So the local anesthetic is injected between this plane, between the transverse abdominis muscle and the transversalis fascia. Here you can see the needle is inserted from posterior to anterior, direction, deep to the tapered tip of transversus abdominis muscle. Between the tip is placed between the transversus abdominis muscle and the transversalis fascia here, and the local anesthetic is deposited. This result in more localized spread of local anesthetic. You can see that injection of local anesthetic creates a visible pocket of fluid. It specifically targets the ilioinguinal iliohypogastric nerve at proximal level as they run deep to the transversus abdominis muscle before ascending into the tap plane. Quadratus lumborum block was reported to provide more extensive abdominal analgesia compared with tap block. Quadratus lumborum muscle, along with the various layers of thoracolumbar fascia, act as an anatomical bridge between the anterolateral wall and the paravertebral region. According to the latest consensus, there are three types of quadratus lumborum block. In posterior quadratus lumborum block, local anesthetic is injected between the quadratus lumborum and the erectus spinae muscles. In lateral quadratus lumborum block, the injection is performed in the plane between the aponeurosis of internal oblique and the transversus abdominis muscle at the lateral border of the quadratus lumborum muscle. I'm repeating, in lateral quadratus lumborum block, the injection is uh, performed in the plane between aponeurosis of internal oblique and the transversus abdominis muscles at the lateral border of the quadratus lumborum muscle. In anterior quadratus lumborum block, the local anesthetic is deposited in the plane between quadratus lumborum and the psoas major muscle. I do practice anterior quadratus lumborum block, which can be performed by shamrock approach or subcostal approach. I prefer subcostal approach because it can be imaged very easily by placing a curvilinear probe, just curvilinear probe in a parasagittal orientation just below the costal margin behind the posterior axillary line. The needle is inserted in a posterior to anterior direction, and the tip is placed between the epimysium of quadratus lumborum muscle and the anterior layer of thoracolumbar fascia. After negative aspiration, the local anesthetic is deposited at this plane. Here you can see the nice distribution of local anesthetic, and if you scan after performing the block, if you scan the in shamrock approach, you can see the local anesthetic has been distributed around the quadratus lumborum muscle. Coming to the last part of my lecture, that is the low thoracic or lumbar erectospinae plane block. This is the latest addition in the abdominal wall blocks, particularly in spine surgeries, renal surgeries, as well as various abdominal surgeries. The dorsal rami of L1 to L4 spinal nerves tend to form three branches. As you can see here, the medial, lateral, and intermediate one, which are distributed respectively to multifidus, iliocostalis, and longissimus muscles. Just like the thoracic erectospinae plane block, the transverse process is identified and the local anesthetic is deposited between the erectospinae muscle and the transverse process. Around 5 ml per segment is per vertebral level is required to cover the lumbar area. For thoracic area, it is around 3.5 ml per vertebral level. Low thoracic or lumbar erectospinal plane block can be performed either in lateral or in prone position. In plane or out of plane technique can be used. One thing you have to remember, that is the injection point is deeper and more lateral in case of lumbar erectospinal plane block, and sometimes it is difficult to sonographically visualize as compared to the more superficial thoracic erectospinal plane block. A convex probe is placed parasagittally and the needle is inserted either in plane or out of plane. Here you can see I am performing both the blocks in out of plane technique. So coming to the complications of abdominal wall blocks, these are needle trauma, particularly in landmark guided approaches. The visceral injury can happen, intraperitoneal injury or intraperitoneal injection and subsequently block failure. The vascular injury and hematoma formation can also happen. The second one is maldistribution of the local anesthetic. For example, inadvertent femoral nerve block and transient quadriceps weakness. In during ileoinguinal iliohypogastric nerve block, the local anesthetic can be distributed towards the fascia iliaca. And in case of transversalis fascia plane or Quadratus lumborum block, the local anesthetic can be distributed towards the psoas compartment and indirectly block the lumbar plexus and result in weakness of quadriceps or femoral nerve block. Others are local anesthetic systemic toxicity and local anesthetic myotoxicity. Last is due to the fact that the intermuscular tissue plane presents a large, well-vascularized surface for LA absorption. To conclude, abdominal wall blocks are technically simple and have favorable safety and side effect profiles. It is usually performed under general anesthesia in supine position. Mostly after induction, we perform it. The fixed analgesic duration of single shot block is an issue because continuous catheter technique, although feasible, are complex and cumbersome. It is difficult to maintain 2 or 4 catheters. So what you can do, you can repeat the block if needed. Choose the block wisely depending on the surgical site, and don't forget to use multimodal analgesia, as these blocks do not cover the visceral component of pain and there is inter-individual variability in local anesthetic spread. Thank you for your patient listening. For more updates, please like, share, subscribe, and don't forget to press the bell icon. Thank you. Thanks all.